This conference will now be recorded.
Okay, good afternoon, everybody. Now you can hear me clearly?
Yes, sir. Yes, sir.
Okay. So we'll be starting with the CBD pathologies today, where we had finished last afternoon. And we're talking about the bile duct obstruction to start with. And if you look at the cause of bile duct obstruction, calculi obstruction is perhaps one of the more common causes. But with the gallbladder calculi, they are symptomatic only in 5 to 8% patients only, right? The rest, 95 to 90% of patients would be there without any symptoms, real. Non-calculous pathologies would account for about by biliary channel growths, compression, external compression. You can have infiltration of the carcinoma gallbladder, or you could have a head of pancreas growth causing a compression over the lower part of the CBD. You could have a stricture, which is amenable to bismuth classification, or you could have a worm infestation. Now, first talking about choledocholitis stone in the common bile duct. If you look at the epidemiology, a primary stone of the gallbladder is found in 12% of cases. That means you have a gallbladder stone, or you may not have a gallbladder stone, yet you find a CBD stone that's found in 12% of cases. Now, we are talking about the primary stone. A secondary stone on CBD is one, if you remember yesterday, we were talking about the complications, a stone getting dislodged from the gallbladder and coming with the CBD, which is perhaps a more common scenario in a CBD stone. So primary stones are found only in 12% cases, and these are usually brown pigment stones. If you remember the lecture before last about these stones and the cause of stones, we talked about the pigment stones, and the black pigment stones are primarily in the gallbladder, and the brown pigment stones are primarily in the CBD. Recurrent stones, if you find a CBD stone after cholecystectomy, now the question could be, or you have done a choledocholithotomy, the question would be that if the patient comes back with the CBD stone, the question obviously is, have you left something behind? Was it basically a stone which you had left behind? Now, one thing is very clear, that a stone found after 2 years of surgery is a recurrent. It's not a remnant stone. That is a very important differentiation. If it is found before 2 years of your surgery, that means you did your surgery, let's say in 2014, and the stone, the patient again had a CBD stone in 2015. 1 year later, that basically is probably a remnant part of the stone which is now grown. If it is found 2017, let's say 3 years later, then it is a fresh recurrent stone. It is not, has to do nothing with the primary stone which he had been operated for, or he had been operated for earlier. So any stone found after 2 years of the index operation, the primary operation, has to be recurrent. It cannot be a remnant. Okay. Now, incidence of infected bile in a CBD stone is as high as 80%. This has to be remembered. That basically means that you have to give this patient a heavy dose of antibiotic as required, depending upon the scenario. If we look at the presentations of a CBD stone, it is silent. Number one, it could be biliary colic, just resembling a patient with a gallbladder colic, except for one differentiation, and that is a back pain is more commonly found in a patient with choledocholitis. The Charcot striate is again very, very characteristic, and here you have basically, because of acute cholangitis, you have the fever, you have the jaundice, and you got the pain, severe pain. Taken together, that forms Charcot triad, which is a presentation of a CBD stone. You can have an acute calculous pancreatitis. We know that pancreatitis could either be alcoholic or calculous. The two common ones accounting for almost 90-95% of cases of acute pancreatitis. So this is an acute calculous pancreatitis, right? Obstructive jaundice, which could be persistent, it could be fluctuating, which could be intermittent. And if you look at the cause of the fluctuating jaundice in a CBD stone, the reason is very, very simple. The reason is that when the stone is impacted, the bile tracks down around the margin of the stone to lie beneath the stone. When it gets filled up, it pushes the stone up so that the stone starts floating. As soon as the stone starts floating, then the bile gets an egress into the duodenum. So the intermittency of obstructive jaundice in a patient of a gallbladder of a CBD stone is because of the floating up of the stone. But that basically means you have to have other causes also. So we look at the differential diagnosis of a patient with fluctuant or intermittent. Now the difference between fluctuant and intermittent has to be known. A fluctuant basically means that you never reach the baseline serum bilirubin level. That means suppose if you had 5 mg/%, you will never reach 1 mg/%. It could come down to, let's say, 3 mg to rise again. That is a fluctuant. If you talk about an intermittent basically means what? From 5 comes to 1, then again rises to 3, comes back to 1, again rises to 7. So it has to reach the baseline at some point. That is an intermittent jaundice. All right. The fluctuant basically never reaches the baseline at any point of time. If you look at the causes of these fluctuant or intermittent jaundice, you can divide them into, these are basically obstructive. Remember, obstructive primarily, there could be some hepatic cause also. Now, the hepatic causes which can give rise to an obstructive feature. Number one, hemophilia. You're talking about fluctuant or intermittent. Hemophilia, a parasitic cyst, a large parasitic cyst which is causing compression over the intrahepatic or a central intrahepatic cholangio. If it's causing obstruction, as soon as the cyst decompresses or is evacuated, that compression disappears, and there you would have basically what? A fluctuant jaundice. Chronic hepatitis, cirrhosis, drug-induced. These are all causes which can give rise to or which can be confused with a obstructive jaundice in that particular patient, right? Then CBD causes, which are perhaps the most important causes. Number one, stone. We already talked about the stone. Number two, Asiatic cholangiohepatitis, primarily because of a worm lying inside the CBD. That worms gets dislodged from that particular area, the jaundice disappears. Drug-induced, viral hepatitis, parasitic liver disease, cholangitis, choledochal cyst, and HIV cholangiopathy. These are some of the causes. That doesn't complete the list, but these are some of the important causes. Then you can talk about the pancreatic causes, the periampullary carcinoma, where the growth at the ampulla sheds itself off, it gets necrotic, sheds off, and the bile starts trickling down again into the duodenum. So the jaundice gets down, right? Recurrent pancreatitis or autoimmune pancreatitis. So these are all causes where you can find a fluctuant or an intermittent jaundice. Okay. Now, the Courvoisier's law. The law is a misnomer. It is not really a law. It should be known either as the Courvoisier sign or a Courvoisier statement. It was never designed to be a law. It was basically put as a law by subsequent surgeons or subsequent investigators. So what does this Courvoisier statement say? We'll talk about the Courvoisier statement, not a law. So what does it say? It says simply that the patient obstructive jaundice, if the gallbladder is palpable, it is not probably because of the stone, full stop. Full stop. It doesn't ascribe a reason as to why it could be there. Now, there is a tendency to increase this law, as it is known, to say that it could probably because of etc., etc., etc. That is not the statement. The statement was only this much, and the statement was that a patient obstructive jaundice, if the gallbladder is palpable, it is not probably because of stone, full stop. Nothing else. Nothing else. No further definitive diagnosis ascribed to this law. That is what we did. That is what the subsequent surgeons did, right? So that is all in the statement. And why this belief by Courvoisier? This is because the stone causes thickening and shriveling of the gallbladder over a period of time. That means if the stone has been there for a prolonged period of time, there has to be changes of chronic cholecystitis. And we all know chronic cholecystitis basically means what? Fibrosis and shortening or shortening of the gallbladder wall, a thickening of the gallbladder wall. So it gets a shriveled appearance. That's why you never see that. But when this was designed, when the statement was made, at that time nobody had even heard of an ultrasound diagnosis. At that time, what was done? They didn't even diagnose a gallbladder soon enough. It was only diagnosed, let's say, after 10 years, 15 years of gallbladder pathology. Then came the time when we had the ultrasound. Now, when the ultrasound came, even with a stone, we used to get, or we have seen in a number of operations, that we get gallbladder wall is absolutely normal. Absolutely normal. So basically, the fancy of the law first was a late diagnosis. If you make an early diagnosis, you can still go against the law. That means even with the obstructive jaundice, if the gallbladder is palpable, it could be because of a stone, right? In the CBD. This is basically not because of a stone where in the CBD. So now because the gallbladder wall is diagnosed early, the CBD stone is diagnosed early as based on the ultrasound. So you can still get a normal gallbladder. If you get a normal gallbladder, the CBD block can give rise to a gallbladder lump. Fallacy number one. Fallacy number two. It says probably not. It doesn't say never. See, it is not probably. It doesn't say it is never because of stone. So that means even at that time, there were a group of patients where the gallbladder was palpable even with the CBD stone. So fallacy number two. Fallacy number one was the early diagnosis because of ultrasound, where the gallbladder is still normal with the CBD stone, you can get a distant gallbladder. Fallacy number one. Fallacy number two, that it says probably, it doesn't say never. Fallacy number 3, an excessively fat person who is not even able to feel or palpate the gallbladder. So you can't say whether the gallbladder is there or not. Fallacy number 4, Asiatic cholangiohepatitis, because of worms found inside the CBD along with the stone. There, the gallbladder may be palpable. So Asiatic cholangiohepatitis. Next fallacy, which is perhaps the most famous fallacy, and that is double impaction of stone, that is impaction at the neck of the gallbladder and impaction at the CBD. Next fallacy, non-fibrotic or non-contract gallbladder with CBD stone, which we refer to as the fallacy number 1, right? Then Klatskin's tumor. Klatskin's tumor, a tumor which is found at the porta, So there is no stone, but the gallbladder is not palpable, right? So no palpability of the gallbladder, even in a Klatskin's tumor, despite the fact that the obstructive jaundice is there. No stone, but gallbladder palpable. Mills syndrome, a large stone in the Hartmann's pouch causing obstructive jaundice. And when it goes into the CHD, the gallbladder is still palpable because of empyema, and there's a stone in the CHD. So again, this is against the law. Stone at the ampulla vator, a stone in the CBD but lodged at the ampulla vator with the normal gallbladder. Again, the gallbladder palpable. So these are all some of the fallacies. I won't say the list is complete. There's some of the important fallacies which go against the tenet of this gallbladder, the Courvoisier's statement. I don't call it a law. Choroidal stone in the gallbladder CBD. How do you diagnose it? Number 1, first diagnose the patient really has an obstructive jaundice. The serum bilirubin to be raised more than 3 mg/%. Conjugated obstructive pattern. AST, ALT usually normal. What we know as SGOT and SGPT. Okay, now the new name is AST, aspartate, and alanine and aspartate, right? Now, ALP would be raised. It will raise. That is one sign which already there, one biochemical parameter always be raised above 150 national units, right? Along with that, gamma glutamyl transferase would also be raised. So 2 enzymes which are raised in obstructive jaundice, along with a serum bilirubin level which has to be more than 3 mg/%. A CBC would show increased neutrophilic leukocytosis, right? Clotting profile would be altered. Would be altered in what form? You'd find an increase in the INR ratio. The PT would be raised. The APTT would be raised. The BT would be raised. Clotting factor, the clotting time, the clotting time will be raised. Bleeding time may probably not be raised because that is dependent probably more on the platelets, right? Infected bile would be there in 80% of patients. Ultrasound, what does it show? 60 to 70% diagnostic rate. It is not 100%. Why? It does not tell you about the retroduodenal part of the CBD. That's why it is not a very good investigation. What is better? An MRCP, even better than CT. Then MRCP is almost 90-95% diagnostic, and it avoids the invasive ERCP in almost 50% patients, right? So that is perhaps probably one of the best diagnostic criteria that you can have an MRCP done with giving a rate of almost 95% diagnosis. And a CBD found to be more than 6 mm diameter is strongly suggestive. Even found on ultrasound, if you have anything more than 6 mm, it is strongly suggestive, should alert you at all costs. You should go in for a subsequent investigation. Even if no stone had been reported, just say CBD more than 6 mm diameter, go ahead and look what is causing this more than 6 mm diameter. It may be normal. It may be normal. It doesn't make a difference. You have to go in for the enzyme and you have to go in for a CT or a MRCP. How do you treat a choledocholitis? Number 1, endoscopic exploration, ERCP with stenting with papillotomy. Remember, when you say stenting, again repeating, it always has to be along with papillotomy. So ERCP with stenting, that is probably one of the good methods doing it, but there are certain lacunae in it. We'll just talk about that, right? Surgical exploration as a lab or an open. For lab, expertise has to be available, and if you have a very large stone, then lab may not be possible. And that's why the indication open has to be expertise not available and large impacted stone. Along with that, what do you require? Either put in a stent or a T-tube. Whenever you open the CBD, it is always better, prefer putting a stent or a T-tube. If you find multiple stones, then it's always safer to do a choledochoduodenostomy when you find multiple CBD stones, or you're in doubt whether you have really cleared the CBD or not. So multiple CBD stones, doubtful clearance CBD, go ahead and do a choledochoduodenostomy done with the first part of the duodenum, and you just attach the lower part of the retroduodenal part of the CBD and atmos it to the posterior wall of the first part of the duodenum. Or else you can also do a choledochoduodenostomy with jejunal fixation to the anterior wall to help in subsequent approach to a recurrent duct stone. right? So you can have an option of DOCO or you got an option of jejunum. Now, ERCP treatment, right? I said we'll talk in slight detail. It's diagnostic and therapeutic. Very good. It is. It can be both diagnostic and help you inject the dye. It tells you everything you can see inside the CBD. And therapeutic basically means you can remove a stone, right? And when you remove the stone, always stent and sphincterotomy. What are the indications? When is it absolutely indicated? You have a worsening cholangitis. The patient is so sick, so septic that you would not like to go in for any kind of surgery at that point of time. Just go ahead and do a ERCP with stenting. Even if you're not able to remove a stone, just stent. Even drainage, what are you draining? Pus inside the CBD. So that's going to remarkably improve the patient for you within the next couple of days. An impacted ampullary stone, again, is going to release the pent-up bile into the duodenum. A biliary pancreatitis, a CBD stone with comorbidities, where surgery may not be possible at that point of time. A patient who is cirrhotic or an older age group, let's say 70 years or 80 years, does not want to have surgery, and you also decide that probably surgery may not be a good option in this patient. So these are some of the indications where ERCP scores above a open operation. What are the contraindications? Number one, a difficult ERCP, multiple stones, large stone. Very large stones cannot be removed by ERCP. If you have a stone shatterer, either based on an ultrasound or you've got the other modalities, basically meaning laser, then you can hope to do it, but that is a very costly. If you have a large stone, it's always preferable to do a lab or an open, right? Intrahepatic stones, again, a difficult proposition, ERCP. Impacted stone, difficult cannulation. If you can't cannulate the CBD, how are you going to do, how on earth you're going to do an ERCP? You can't. A CBD divertically, a duodenal divertically, a biliary stricture, and post-gastrectomy, where it is very difficult to go ahead and cannulate the CBD, as is seen after carcinoma stomach, peptic ulcer disease, or bariatric Roux-en-Y. So these are some of the areas where doing an ERC becomes very difficult. These are basically the relative contraindications. None of them is absolute. These are relative contraindications. Complication rate is again a negative point, which works against ERCP. 5 to 8% acute pancreatitis, ileus, cholangitis, and bleed. So all are working against a ERCP. Clearance rate is again not 100%. See, one time 71 to 75%. You do it multiple times, then you can have a rate of 84 to 95%. Okay, so these are basically the pros and cons for ERCP. Then comes the surgical CBD exploration, open or laparoscopic. I'm not going to go into the details as far as you're concerned. That's not really required. Even for the PG, they should know the principle. And lap approach could either be transcystic or transducal. Transcystic basically means you're going through the cystic duct and entering the CBD. The transducal means you're making direct opening over the CBD and entering into the CBD. Now, transcystic, what is basically required is that you should be having a wide cystic duct, or you should have a cystic duct which can be dilatable to 8 millimeters, right? If you can dilate a cystic duct to 8 millimeters, if you can do that, you can go ahead and do a transcystic. If you can't, then you have to go in for a transducal. Is that clear? So 8 millimeters either in its form by itself or dilatable to 8 millimeters. Go ahead and do it. You can easily insert a fiber optic choledocoscope. Right. So transcystic, minimum 8 millimeter, I told you, dilatable. Procedural details, just short cystic dilatation done. Then you can go ahead and put in a choledocoscope, put in a dormia, extract it, or do a lithotripsy at that point along with the choledocoscope, and that is the end of it. In addition, you can also do anti-grade papillotomy. Now, normally when you do a ERCP, the papillotomy is done from there, from the duodenum entering into the CBD. That's why you do it. You're cutting the ampulla. Now, suppose if you're coming from the CBD into the duodenum and then doing a papillotomy, that is anti-grade papillotomy, right? So that is the difference. So you can do an anti-grade papillotomy coming from the CBD into the duodenum. A choledocoscope is always required and expertise has to be required. So it's not a very easy procedure to do. What is probably easier is the transducal, which can easily be done even with a rigid. Now, with a rigid, you can never do a transcystic. You can't do it. Remember, you're going to tear everything up, right? So you have to have fiber optic for transcystic. Transducal can be done with rigid or fiber optic choledocoscope. Stenting and T-tube required, which is not required in transcystic. You don't require any kind of stenting there. You don't require stenting a T-tube. Here you do. Complications, CBD injury, tear, retained stone, duodenal injury at ampulla, bleed basically from the posterior portal vein can bleed from that particular particular patient, or hepatic artery bleed when you're trying to do a transducal and accidentally you go too medially and you cut the hepatic artery. Where's the hepatic artery lying? Medial to it. So hepatic artery, then you have the CBD, and behind you have the portal. Remember, medial to lateral, hepatic artery, and then you have CBD, and posterior got the portal vein. So if you perhaps puncture the posterior wall of the CBD, what's lying behind? The portal vein. You can cause bleeding from there. So injury to the CBD or an injury to a medially lying structure, that's the hepatic artery, or a posterior lying structure, which is the portal vein. It is better than ERCP. Why? Because it could be one single stage operation for both gallbladder and CBD stone. That is the advantage of a lab exploration over ERCP, or an open exploration over ERCP, where the ERCP, the endologist basically just clears what? He just clears this, the CBD, and the rest a laparoscopic or open gallbladder has to be done. So it's a two-phase operation. Here you're doing basically a single-phase operation, right? So one sitting lap chole with lap chole to chole. The second cause for CBD obstruction is basically worms, Ascariasis, cholangiocarcinoma, and hydatid. Now cholangiocarcinoma basically is not found, fortunately, in this. It's basically Mediterranean disease, and there you find this worm out there. Complication same as in Ascariasis. What are the complication? We remain there for a prolonged time. It dies there, cause stricture, cholangitis, liver abscess, impairment of the gallbladder. All possible within Ascariasis lying inside the CBD. Now, you can give antispasmodics to relax the CBD. You can give, you can do ERCP, drag it out, or you can do a CBD exploration. Now, short of that, remember one thing: do not use a vermicide with a live Ascarias inside the CBD. Do not. If on ultrasound you can see the worm wriggling, you can easily see it. You can see the Ascarias wriggling on an ultrasound. If you see that, do not use a vermicide. Don't use that. Why? If you kill the Ascarias there, it is not going to be expelled by itself. Then you have to go in for a ERCP. But if it is alive, it can easily come back into the duodenum by itself. So you can easily follow by an repeated ultrasound. So until it's alive, don't use a vermicide. Once it dies out, yes, go ahead and use vermicide. And for CBD clearance, a better proposition would be an ERCP, right? The same thing with cholangiocarcinoma. Hydatid, usually part of the hepatic hydatid rupture, where the hydatid ruptures intrahepatically into the cholangioles, and through the cholangioles, these vesicles now lie where? The scoliosis lie where? Inside the CBD. And they are blocking the CBD, giving rise to obstructive jaundice. So basically now at this point of time, you have to use a medical therapy, and you have to do a ERCP clearance or a laparoscopic clearance, right? Now the medical therapy is important. Just to tell you about this, just a short reminder what has been done for the cystic echinococcosis, which is known as a benign hydatid disease. Here it is the cystic form. Two benzimidazoles derivatives can be used. Number one, albendazole. Number two, albendazole. And albendazole is the preferred. Why? Less side effects. Administered in several 1-month oral doses of 10 to 15 milligram per kilogram per day, separated by 14 days interval. Very easy to remember. You give it for 14 days in 1 month, and give it for minimum 3 to 6 months. Nothing very problematic about it. So you can increase it to 15. So you can say 15 days per month for 6 months. Easy to remember. 15 days per month for 6 months. Simple. And the dose 10 to 15 milligram per kilogram per day. Right? Mebendazole can be given again for 3 to 6 months orally. The dose is almost 3 times, 40 to 50 milligram per kilogram per day. Do you combine praziquantel with it? You may combine praziquantel with it at a dose of 40 milligram per kilogram per week. See, it is a week. It is not per day. It is per week. Okay, especially in cases where intraoperative spillage has occurred. So you're removing the hydatiditis, doing it laparoscopically open, and accidentally you rupture it, and you feel that the vesicles have not been accounted for. You have not been able to remove all the scoliosis. Some of the scoliosis are lying inside the abdomen. There, that creates a problem, right? And in that case, a follow-up of 2 weekly. If you're using these drugs, every 2 weeks you should get a CBC and liver function test done. Why? Because even albendazole is liver toxic. So you're looking for the liver enzymes. What is the response rate? 1/3 cyst disappearance if you're using it not as an adjuvant, you're just using it as a primary therapy. 30% cysts disappear, 30% decrease in size, and 30% no change. Just remember, 1/3, 1/3, 1/3. That makes it 3/3, right? 3/3 basically means 1. So 1/3 cysts disappear, 1/3 they don't, they just decrease in size, and 1/3 is absolutely no change. Younger adults, they respond better than older adults and is preferred as adjuvant treatment, especially in those with spillage. Okay, now chemotherapy of the second variety, which is known as the malignant form of hydrated, which is the alveolar echinococcosis, and this is a highly morbid disease. I'm sorry for this typo error. It should be highly morbid disease. What are the indications? They are used perioperatively. So here, benzimidazoles are to be used perioperatively for approximately 2 years. There we're talking about 6 months. Here we're talking about 2 years in patients whom radical resection is feasible because of possible undetected residual parasite cysts. Now remember, these are multiple cysts and you can never do a cystectomy or pericystectomy in a patient of alveolar type. It is studied all over the liver. So ultimately land up with what? Either segmentectomy, partial hepatectomy, or even at times you have to go in for a total hepatectomy and go in for liver transplantation for a cystic disease. Remember this, not a cystic disease, for a hydrated disease. If this is alveolar variety, why? It is studied all over. So partial resection, inoperable, or who had a liver transplant, long-term chemotherapy for 3 to 10 years. See this, 3 to 10 years. You have to continue with this drug, right? Contraindications, pregnant female and severe leukopenia, you don't use it, right? So patient, the monitoring, again the same. Outcome, increase in 10-year survival rate in patients receiving chemotherapy compared to patients who are not treated, right? So just remember, with the alveolar variety, if you have a CBD obstruction in these patients, the treatment has to be medical. What about CBD stricture? Now let's talk about CBD stricture. Causes are simple: atresia, which is most commonly a congenital problem, a post-operative, again more common. So the most common cause among all these, the most common is the post-operative, right? Cholecystectomy, gastrectomy, hepatic section, liver transplantation. All are possible causes for a post-operative CBD stricture. Inflammatory, you can have recurrent bouts of cholangitis, you can have the worm, we just talked about that, you can have stones, we talked about that, pancreatitis, sclerosing cholangitis, radiotherapy, all causes. Then you can have a congenital CBD atresia, we talked about in the last lecture. Trauma is another cause, and idiopathic, you don't know what is causing this stricture. Signs and symptoms, the signs are very simple: recurrent cholangitis with or without jaundice, you can have a gallbladder lump, you can have hepatomegaly. All could be signs of a CBD stricture. The diagnosis, the best is a cholangiogram. You can get some kind of an indication of a possible stricture when ultrasound and CT scan, where you find a proximal dilatation. But cholangiography is probably the better method to do it. And cholangiography, you can do a cholangiogram by injecting the dye from below, as is done in ERCP, or you can do it with an MRCP, or if you want to inject the dye through the liver, there is transhepatic, the percutaneous transhepatic cholangiogram. You go through the skin into the liver, and you directly put the needle into one of the cholangioles and inject the dye. That is PTC. Or if the T-tube inside, you can do a T-tube cholangiogram. So cholangiography can be done by all these 4 methods: ERCP from below, from top PTC, and MRCP by magnetic resonance, and you can do a T-tube cholangiogram. Coming to biliary stricture classification, the Bismuth classification is very simple, and this is basically nothing but the E of the last classification we talked about when we were talking about the CBD injury, right? So here you are again talking about 2 centimeters more or less than 2 centimeters, right? So this is more than 2 centimeters, type 1, less than 2 centimeters, type 2, right? Type 3, you reach the porta, but you still got a patent interductal collection. If this connection is no longer there, it's type 4, right? And type 5 is a combination of a CBD along with one of the sectorial ducts. Right? That is the Bismuth classification for a bile duct injury. Treatment: 50% a percutaneous or endoscopic dilatation and stent placement. Either dilate from below or dilate from a percutaneous, right? Keep a dilator inside and put in a metal stent or put in a plastic stent. Okay, that should be all, and it does make a difference in almost 50% of patients. In the other, if you're not able to do that, then you have only one resort, and that is doing a primary anastomosis. You have to anastomose the part where you find the stricture, and you have to cut it just proximal to it and do an anastomosis. And which anastomosis is preferred? A Roux-en-Y choledochojejunectomy. We can also do a hepatocojejunectomy. In which type? In this type. What can you do? You can't do anything here or here. It has to be hepatocojejunectomy, which is also a portojejunectomy at the porta. This you can do a hepatocojejunectomy, but it's at all times has to be an anastomosis where you attach the jejunum to the Grison's capsule around the porta, which we have repeatedly stressed along the lectures, right? Coming to primary sclerosing cholangitis, not an uncommon disease. It is basically a type of fibromatosis. Have I written it somewhere? Yes, part of fibromatosis. And just to define, fibromatosis is a non-malignant benign condition which is because of excessive multiplication of fibrocytes giving rise to a hyperplasia of fibrosis in any one tissue, in any one organ. And just to tell you what the fibromatosis are all about, if you go from top to bottom, this as a passing reference, I'm giving you this information, just note it down if you're not noted anyway. So starting from top to bottom, the important ones I'm telling you, the first is Riddle's thyroiditis. It is a fibromatosis, right? Mediastinal fibrosis. Coming down, retroperitoneal fibrosis, the midline one. Now let's go away from the midline. From here, a primary sclerosing cholangitis, right? What else? What else is there? Is a Dupuytren's contracture. That was contracture, and the corresponding part in the plantar area, that is plantar fasciitis, right? Dupuytren's contracture, plantar fasciitis are part of this. Peyronie's disease is a part of this. So at least 5 or 6 conditions now you know, which are all fibromatosis, which are hyperplasia or the fibrous tissue for unknown reason. Similarly, primary sclerosing cholangitis, we still don't know what is the reason. Idiopathic, see, idiopathic progressive fibrosis. And involving what? Inside the liver and outside the liver, intrahepatic, extrahepatic. Does it have an immunological basis? We don't know. We do have a raised antinuclear and smooth muscle antibodies, but that is not confirmatory whether they are causing this PSC, right? Usually seen 30-60 years male. Associated inflammatory bowel disease like ulcerative colitis is a significant finding, and probably ulcerative colitis also has to do something with fibromatosis that is not conclusively proved. What are the investigations? Again, simple cholangiogram. And the cholangiogram, the 3 methods we already enumerated. And along with that, you have to do a liver biopsy. Easily done percutaneously, right? It has to be differentiated from a secondary sclerosis and cholangiocarcinoma. That is one of the most differentiating diagnoses, and the differential has to be done from cholangiocarcinoma. Treatment, stent. If not possible, you have to go in for resection if possible. Ultimately, you land up with what? A liver transplantation if it is involving both the intrahepatic and the extrahepatic. Extrahepatic involved, the only resort is liver transplantation. Is that clear? Then a new entity which has been described recently is IG4 related cholangitis. A diffuse or a segmental narrowing has to be differentiated from PHC or cholangiocarcinoma and pancreatic carcinoma. Associated with what? Increased IG4 levels, autoimmune pancreatitis, IG4 related sialoiditis, and retroperitoneal fibrosis. So these are again, see, what are these? They are basically, we just now enumerated as a fibromatosis, part of them. Diagnosis, you do a biopsy, lymphocytic, plasma cells are there, and the treatment has to be steroids. Okay, biliary duct neoplasia, which are very important. The benign ones, just to enumerate them: papilloma or adenoma, multiple papillomas, granular cell myoblastoma, neural, leiomyoma, and endocrine. Among these 2 are important: the papilloma or adenoma. Why? Because they are most frequently at the periampular region, and they jut out like a villi. They jut out like a small papilloma to the ampulla of right? Jaundice in 90% cases, and the treatment is total resection of the periampullary area. Multiple papilloma they found. These are mucous, which is intermittent cholangitis, pre-malignant. It is pre-malignant. That is again very important, pre-malignant. And you have to go in for liver resection with liver transplantation in those patients who got multiple papillomavirus. Coming to the more important, the last part of this lecture, and that is multiple biliary duct neoplasia or the malignant cholangiocarcinoma, right? Now, the division of cholangiocarcinoma is broadly into 3 types. One, toward the hilum, second, toward the ampulla, and number 3 is basically the intrahepatic. Okay, now incidence is 1 to 1.45 per 1 lakh. That is a very, not a very common, a very uncommon. Peak at the 8th decade, male, female, probably more common in males than female. Usually multifocal. That means you don't have one single foci, you have multiple foci. And usually diagnosed at an advanced stage. That means this part is very unfortunate for the patient and for the surgeon, that you usually get to diagnose a cholangiocarcinoma pretty late in the disease. right? The three anatomic regions I just not told you: the intrahepatic inside the liver, the extrahepatic, that is perihilar in the region of hilum, and distal extrahepatic, that is near towards the ampulla. Perihilar is characteristically known and famously known as the Klatskin's tumor. And these are the most common cholangiocarcinoma. That means the one at the hilum is the most common type of cholangiocarcinoma. At the bifurcation, right and left hepatic duct, and it is as common as 60% among all, right? Second common is the distal extrahepatic, and the least common is the intrahepatic tumor, right? So most common, less common, least common. Okay. Now, 80 to 85, 90% are present with unresectable or metastatic disease. That is the crunch of the problem. That means only 10% of patients, when they come to you with cholangiocarcinoma, 10% of them would be amenable to some kind of a therapy. The rest of them will not. Right? The classification most commonly followed is the Bismuth correlate classification for perihilar. The black area is the tumor spot. Right? If you don't want to, you can afford not to remember, but you should just remember it can be found at three sides: the perihilar, the distal, and the intrahepatic, right? And in the order of commonness. Okay. Now, if you look at the etiology of this bile duct cancer, it is undetermined. We don't know why it is occurring. Long-standing inflammation could be one of the causes, as we suggest to play a role. And what does the long-standing inflammation do? It induces hyperplasia of the biliary cells lining the duct. Then it leads to cellular proliferation, DNA mutations, and ultimately malignant transformation, right? Like with primary sclerosing cholangitis, which is the pre-malignant condition, 20 times the risk, and at early age, see, 20 times risk at early age, 30, 50 years. Chronic parasitic infection, Escherichiasis, liver fluke, and Helicobacter, does it have a role? So all these, whether it's a parasitic infection, it's a primary sclerosing cholangitis, they're all pre-malignant. They all lead to increased susceptibility to the development of cholangiocarcinoma. If you have by chance PSC together with ulcerative colitis, Crohn's ulcerative colitis or Crohn's, then you basically are a further increased susceptibility. You're further increased susceptible to the generation of a cholangiocarcinoma, and that also the intrahepatic type, which is the worst type. Chemicals like ERCP industry, rubber industry, wood finishing industry, where you got vinyl chloride, asbestos, digoxin. These are again areas where you got an increased susceptibility to cholangiocarcinoma. The other predisposing scenarios could be congenital disease of biliary tree, like for example choledochal. Remember we said that excision has to be done. If we're just doing a bypass, that patient will be susceptible to cholangiocarcinoma. So choledochal says Caroline's disease, bile duct adenomas, we just talked about that, biliary papillomatosis, alpha-1 antitrypsin deficiency, and obesity. These could all be a predisposing factor for the development of cholangiocarcinoma. What is the pathological type? Ductal adenocarcinoma. That is almost 95. 5% could be a squamous cell carcinoma. So 95% ductal adenocarcinoma, usually of the well to moderate differentiated adenocarcinoma, which is perhaps the only redeeming feature. It's not the poorly differentiated, it's probably well moderately differentiated, where you can see the glandular or acinar structures still maintained. They're still preserved. Those structures can still be seen. That's why it is well to moderately differentiated. Intracytoplasmic mucin is always observed. You can see that intracytoplasmic mucin, that is intracellular mucin. Here the cells are cuboid or low columnar and resemble the biliary epithelium. That itself shows you that it's well to moderately differentiated. Once they lose the biliary epithelium scenario, then it becomes poorly differentiated. In more poorly differentiated tumors, solid cord of cells without lumina, we do not maintain the resemblance to the biliary epithelium. Mitotic figures are rare, again a plus point in favor of well to moderately differentiated. A dense fibrous stroma is characteristically and may dominate the histological architecture. You get a lot of fibrocytes, right? The tumor cells provoke variable desmoplastic reaction. That's why you get this fibrous stroma. That is the desmoplastic reaction. How does it spread? Number 1, intraluminal. Number 2, lymphatics. Number 3, blood vessel. Number 4, perineural. And then periductal spaces and the portal tracts, right? Along the lumen large bile ducts, we just told you, they can be seen, especially with the hilar tumor. That's the spread of this tumor. So all known spreads, the vascular, the lymphatic, the perineural, the periductal, the interluminal, and the portal tract, all possible methods it can spread. The clinical features, It's an early weight loss, abdominal pain, cachexia, late jaundice, clay-colored stool, bilirubin raised, and pruritus. They're all features. They're just saying obstructive jaundice. In the early stages, the consumptive features in the form of abdominal pain, weight loss, and cachexia. Jaundice late in the perihilar or intrahepatic tumors are often a marker of advanced disease. So once it appears, it tells you that look, this patient, if he has cholangiocarcinoma, cholangiocarcinoma, it is pretty late in the advancement of this disease. Early jaundice in distal CBD cholangiocarcinoma is the redeeming feature. Pruritus is usually preceded by jaundice. You can have a gallbladder lump, which is known as the Courvoisier sign. We just talked about the law, and hepatomegaly in 25% of these patients. The differential diagnosis of cholangiocarcinoma is important. Why? Because you don't make a diagnosis of cholangiocarcinoma very easily, although it's always kept in the differential diagnosis. But making a primary diagnosis of cholangiocarcinoma is not very easy. Why? Because the number of other pathologies given us to the same presentation, like for example, a bile duct stricture, a bile duct benign tumor, a biliary parasitic disease, an external biliary obstruction, cholangitis, variant of acute cholestasis, choledochal cyst, choledochal lithiasis, carcinoma head of pancreas, periumbilical carcinoma. So all of them, all these are basically in the differential diagnosis, and the last of them should be the cholangiocarcinoma. It doesn't come here. It doesn't come here. It comes somewhere here. That means once you've considered all these causes and ruled all of them out, only then you make a diagnosis of cholangiocarcinoma. The investigations, again, investigations for what? For obstructive jaundice. You have elevated conjugated bilirubin, you have a raised alkaline phosphatase, you have a raised gamma glutamyl transferase, the levels of aminotransferase aspartate alanine are probably normal. We just not told you that. The biochemical test for hepatic function, the albumin, prothrombin are normal early disease, but when it comes to late disease, the albumin level falls and the prothrombin time increases. With prolonged obstruction, it said prothrombin time increases, and because of vitamin K malabsorption and the INR increases, right? International normalized ratio increases. Hypercalcemia could be occasionally seen in the absence of osteolytic metastasis. The tumor markers, which are probably helpful as a prognostic indicator in cholangiocarcinoma, are two: CA19-9, this is a carbohydrate antigen, and you can have a carcinoembryonic antigen. All right. Investigations are basically the investigation done for any biliary channel disease. Just remember the ultrasound, CT, MRCP, MRA. We already talked about that. The MRA is especially useful for the arterial pattern along the CBD if you have to operate on this patient, remove the CBD. So this prior information has to be there. But apart from this, what are perhaps equally important is the positron emission tomogram. Why? It shows small lesions. It also shows underlying PSC. And it also helps in detecting nodular carcinoma and unsuspected distant metastasis. And that is why a PET is now becoming increasingly important in a number of other malignant conditions, not only for a cholangiocarcinoma. Endoscopic ultrasound, how does it help you? It helps you to evaluate the whole of the CBD by an ultrasound. You're going through the stomach. So you've basically got this, the picture of the complete CBD. It also permits aspiration with cytological studies. Intraductal EUS allows direct ultrasonic evaluation, right? So that is why an endoscopic ultrasound is important in these patients. And then, of course, a PTC or ERCP, depending upon whether you're looking at the distal cholangiocarcinoma or proximal cholangiocarcinoma. If it is proximal, you go ahead and do a PTC. If it is distal, then you go ahead and do a ERCP, right, for distal tumor. So level of obstruction for biopsy, because you want to take a biopsy, and to biliary stenting for drainage. Okay, combining the findings of cholangiogram and arteriography, that is MRA and cholangiography, has been found to be a combination which is very good to decide whether you can go ahead and do a surgical resection or it predicts a unresectability in that particular patient, right? Staging, I would not like to go into the staging. Why? Because intrahepatic staging is different, the perihilar is different, and distal tumor is different. That means there are three different types of staging for the same disease, cholangiocarcinoma, depending upon the site. Whether it's intrahepatic, it's basically the hilar, or it is the distal. Three different stagings. So I have not put the TNM staging out here. That is beyond learning, and then you have to look it up when you're dealing with a patient with cholangiocarcinoma. The treatment depends upon what? The size and extent comorbidities, and coexisting liver diseases. All three have to be taken into account. And of course, the vascular involvement and the metastasis. If you take all these five into account, only then you can decide whether you want to go in for excision or not, right? Now, if you look at this, 10 to 15% for R0 surgical excision. R0, remember, whenever you say R0, you're talking about microscopically clear margins. Remember, when you say R0 anyway, it's not only for stomach. Forget that. It R0 basically means you have to have a microscopically free excision margin. That is R0. So you're looking for R0 surgical excision possible only in 10 to 15% of cases, right? That may or they may have to be combined, not in all cases, may have to combine with standard or extended liver resection with distal Whipples, or proximally may require a liver transplantation. So that tells you what formidable disease we are talking about. Doing a Whipple's operation along with the excision of the liver, what can you hope? The mortality, it shoots up. Adjuvant chemo and radiotherapy could be advised or required in these patients, right? Rest, that means this was 10 to 15%. What about the rest patients? Only palliative therapy. And what palliative are we talking about? Palliative or non-resectable, almost 80, 85, 90% of patients. Stenting, either way, PTC or ERCP. If you got a lower growth, push in a stent through it. And which stent is better? Whenever you want to stent, you have to have a metal stent. That is preferable. It is costly, but it keeps the whole thing open. If you are using a plastic stent, a salaric stent, what happens? As the growth increases, it collapses the stent. The stent gets blocked, and then you have to do a restenting. That's why the metal stent is to be preferred whenever you talk about any kind of malignant stent. For necrosis malignant, you have to go in for a metal stenting. Okay. Now, if you have got a proximal Klatskin's tumor, the stenting has to be done through the PTC. Photodynamic therapy is one of the methods which is now creeped in. Here, basically, you're talking about two-step procedure. The first step is an intravenous administration of photosensitizer, and then the second is you use a light illumination at an appropriate wavelength so that that particular photosensitizer is sensitized and that kills the particular cell, right? That is effective in restoring the ability to drainage, improving quality of life. It doesn't cure you. So used in non-resectable and disseminated cholangiocarcinomas. Okay, several times may be longer than those reported previously. That basically means that what we know about PDT initially and now we know about today, probably PDT results are probably better than what we expected in the past. Radiation therapy as a operative, intraoperative radiation therapy is probably better. And you can use the intraluminal brachytherapy, you can use external beam therapy, or if you want, you can use it as an adjunctive post-operative. That improves the local control with variable effect on overall survival after complete resection. Chemotherapy can be tried by 5-FU and gemcitabine. Targeted therapy can be tried. You can use pemigatinib, that is one previously treated, unresectable, locally advanced, or metastatic cholangiocarcinoma. These scenarios we like to use a targeted therapy with a fibroblast growth factor. You're going to type. Remember, we said desmoplastic reaction. Your desmoplastic reaction is basically under the effect of what? Fibroblast growth factor. So use some kind of a drug tagged to fibroblast growth factor. It is going to go and localize in the area where there is a desmoplastic reaction. That is why it is known as targeted therapy. So I think that is all about the gallbladder, which we have used a lot of lectures in that. And thank you very much for your time.